Welcome back, ladies and gentlemen. It is wonderful to see you here again on this afternoon. Who learned something since we saw each other last? Yes, we're still in learning mode, as we should be. Very good. Well, that is wonderful. We are going to learn some more together this afternoon on stage, and hopefully also off stage as you connect with each other. But we're going to start off with perspectives where people built companies based out of the UK for the world. We're going to dive deeply into the topic of data and patient records and explore that from different perspectives. And of course, a big topic in that is digital trust, to take that away from the start. First off, our first keynote speaker built a patient control health records long before they became fashionable. And he's someone who understands this topic of digital trust, not just as theory or as a slide deck or as a strategy, but as lived experience. And so I'd like you to welcome warmly a wonderful first keynote speaker this afternoon, Dr. Mohammad Al-Ubaydli, here on stage with us. Welcome.
Thank you very much. If I speak at this volume, can you hear me at the back? Good, wonderful, thank you. Let me see if I get this working. Perfect. This slide is supposed to make you believe I did used to have hair. This is myself with my mother and father. And I wanted to start by telling the story of the only time I heard my mother cry. I made her cry. I grew up in Yemen. It was a very tough environment. My mother used to walk 1 hour to get to a bus station where you drive 1 hour to get to the city where you could have one bottle of Coca-Cola. Now, in that environment, I was born with genetic immune deficiency. And my mother noticed early on that I was getting infections much more than other children were. So because of her education, she then began boiling water before I could drink it so you could make sure it's clean. And everyone told her that she was spoiling me, she was raising me to be weak, but she said, no, I can tell there's something different about this child compared to others. And when I eventually came to the UK and a doctor diagnosed my illness, they were amazed that she'd managed to keep me so healthy. But the one time I heard her cry was I refused to take my medication. I was 15, I was so fed up of being sick and taking medicines that I stopped, and that drove her to tears. But what she was really worrying about is what happens if she's not around? Who is going to take care of me if I don't take care of myself? She eventually taught me how to understand my health, look at my test results, inject myself, all of these things, and I became independent. But what my interest is how does everybody else get that same opportunity? How does everybody else get their education to look after themselves and the data to be able to look after themselves? And what I want to talk to you about today is what that looks like in different countries and what different people are trying to do. Everything I'm telling you about, it's in a book called Personal Health Records for Governments. It's open access. You can read the whole thing online, or if you will come for me afterwards, you can get a copy of the paper book. You all know this. Every country, there has been rising life expectancy. And the reason for the life expectancy is that chronic conditions that used to kill people, now people live with them. So that's happening in every country in the world. The big thing, though, is who is financing these people who are living with conditions for longer. This is from different countries, low income in the top left, high income in the bottom right. Look for the dark blue line. That's how much of the money is coming from government spending. And what you see is that every country, as it gets richer, it spends more as a percentage from tax funding, from government funding, than from out-of-pocket investments. So anyone who's telling you that the private sector will step into finance isn't looking at the data. And the richer countries, every year they spend more, and that increased during COVID. People are looking to the government to finance long-term condition management. So where does the money go on? Well, it goes to rare diseases with complexity. So I have a rare disease, but lots of people have a rare disease. And together, 1 in every 17 people in England have some kind of rare disease. Some of it is longevity, so people with long-term conditions, and then multiple conditions. And then distance. People travel long distances to get to the specialist who understands their situation. This map shows you from people using Patients Know Best, our system, which gives people their medical records. In London, half the people who come to the hospital are from outside of London. But even the rest of England, 25–30% of people are from outside. And if the data doesn't come with the person, then the healthcare is expensive, inefficient, and sometimes unsafe. So every country needs to allow the data to move with the person, and every country is relying on the government, but the governments can't build these systems. In the book, we cover 16 different countries. 15 of them, nobody has a database for more than 5 million people. The only exception, the 16th one, is Saudi Arabia, but Saudi Arabia is governed differently to European countries. There's Spain, Italy, Sweden, they all want local regional databases for privacy reasons, for European values. And on the other side, because they're government-run, they miss out on the most important data set for the 21st century, which I'll tell you about, which is the data that comes from the citizen. So these data sets are excluded from the government infrastructure, and the government needs an infrastructure that works for a whole nation. Because people who can look after themselves mean the health economy is affordable. If we carry on in the same way with the doctors and nurses having to do everything for the citizen, there's not enough money, there's not enough people. Only if people get trained and have the data to look after themselves can a society remain solvent in the 21st century. So what I'm going to cover is, this is a nice report from the UK about what can you do if you have that single record around the patient. How can you allow that infrastructure to happen? It starts with integration, then you allow automation with all that deluge of data, and then you get to motivation of the person being able to change their habits. So the first thing to do is integration. Different people try slices of the problem, but unless they tackle the fundamental problem, it's a waste of effort. So if they try and do a hospital portal or a primary care portal, of course, the most expensive patients are the ones that have multiple providers. Sometimes they do a disease portal, something for diabetes, another thing for kidney disease, but of course, diabetics get kidney disease. Sometimes they do a regional portal, but patients ignore regional plans. They travel everywhere, and the data must go with them. Sometimes you try and do apps for appointment booking or prescriptions, but again, the more apps that salami slice things, the less engagement for the citizen. And then when I started in 2008 working on this problem, the idea was that Google and Microsoft and Apple would solve this with their smartphones, but all they did was create a new silo on the patient's phone, separate from the doctor's infrastructure. So we started with an idea that all the data about the patient comes into one place, and it goes to wherever it is the patient needs it to go, whether it's the patient seeing it or their healthcare system seeing it, or an app that serves the citizen, their patient. Now, the critical thing we discovered over the last few years is that the data from the patient is critical. Let me tell you what that means. So in the 1980s, Omron, the Japanese blood pressure company, said, let's try if a consumer at home can measure their blood pressure. And everyone said, you're mad, you're naive, of course the patient can't take the blood pressure. And what became apparent is not only can the consumer do it, but they are better at it than the doctor. Why is that? Well, one simple reason is if the patient's doing it at home, they're not stressed about doing it in front of the doctor, so white coat hypertension disappears. But the other thing is the biggest indicator of accuracy is frequency. The more blood pressure measurements you take, the better actual understanding you have of that patient's cardiovascular status. And who has the time to take many measurements? It's the patient. And this now extends as you have the smartphone. So this is a FDA-certified device that will do all kinds of vital signs just from the camera of your phone. So these data sets are now more accurate, more complete, because they are more frequent and more real-time than anything any healthcare provider is able to deploy on the ground. But the problem is government infrastructure tends not to know how to cope with this. So there's a technical risk of storing all that data. They worry about how do you manage that, especially around the privacy of combining it with other data sets that citizens worry about the government holding that much about them. And then the other side is the clinical risk of the clinicians themselves don't know what to do with that data, And they worry that if they have access but they don't take action, they are liable, so they prefer to see none of the data. And so the governments then shrink away from that data set, and the healthcare system misses out on this advance. So what I want to show you is what different countries have done from around the world. So I've got two extremes. So one extreme is the Nordic countries. So countries like Denmark build their own system top to bottom. As you can expect, it's highly effective as a government, but it's very limited. They can't advance beyond what the government built in the early years, and it becomes frozen in budget and time. And the other end, I call that Mad Max. This is the USA, which is completely open, completely free market, and so the consumers are taken advantage of, and the healthcare systems compete over data and fight against integration. Some countries like India set government rules and use the Indian scale, but they still haven't got the competition problem solved. England is the one I want to highlight, where they basically had a national brand with the NHS app, which everyone during COVID was taught to use. But the government admitted that it couldn't build the whole thing, and so it began contracting different parts of it. So you had a market, a mid-sized market, 57 million people, in which to swap solutions in and out to deliver something under the government's governance. Now, here's what that means in practice. So for us in England, 125,000 people register every month. We release them 22 million test results. Because you have the government brand pushing the citizen that everything will be in one place, you get a lot of registration and a lot of data release. So the Dutch system, for example, with the PGOs, doesn't have that central push because it leads too much to the citizen to bother with. Too few bother with it, and too little data is released. But if you have that single central message with the private sector, you get a lot of registration, a lot of data release. And then this is what it looks like in practice. So the blue top is built by the government, and everything below that is built by private provider, in this case, Patients Know Best. So all the advanced functionality around data release, you combine the public sector with the private sector. We operate in 10 different countries. Each of those has a slightly different model, but that partnership between government and the private sector is very repeatable. And what it enables is a citizen who then can open up their record to any innovator, not just the ones the government feels comfortable with. So the data that comes from these new devices, the consumer can engage with them. And AI systems that become available, the citizen can also choose to engage with them. Now, for comparison numbers, so I'm very proud that we have 125,000 registering every month. In India, they have 400,000 every day registering in the system. It's a completely different scale from the sheer size of the country. But the market dynamics, where the providers want to hold on to the data so they can hold on to the patients to hold on to the money, means very little data is released. So the regulator hasn't stepped in to mandate more data release, and there isn't a dominant public sector where the public sector likes to release data, whereas the private sector likes to lock the data. But you can see different models in different countries. Once you've got the integration in one place around the citizen, you can start doing the automation, because the thing that clinicians are most worried about is, what do I do with all this data? What am I liable for understanding? So you must have automation to pick out who needs attention and who you can safely, defensibly ignore. I'm going to show you one example from the Netherlands, which is See My Life. It was originally built by Radboud UMC, and they focused on blood cancers, chronic myeloid leukemia, CML, See My Life. The interesting thing I want to show you is, so their architecture is they get the data from the personal health record, the PGO, and then build a workflow on top that automates how to treat blood cancers. The thing I want you to see from the diagrams here is the way they show test results is completely different to anything you'll find in a traditional doctor's medical record system, because it's so specific to the workflow of blood cancer. And every disease has a completely different workflow, and you need to allow these user interfaces to emerge, these workflows, these automations to come into place. So I think this model should be repeated for every single disease. And finally, you end on the motivation aspect of things. So what does the citizen do now that they have the data? How do they actually take action? Because the healthcare system doesn't actually know how to do behavior change, and increasingly it doesn't have the ability to do behavior change. So this is in England. every year for 3 decades, the English government contacts a sample of the patients in every primary care provider. And they ask them 2 questions. Do you have a favorite GP? And do you get to have an appointment with them when you want? And you can see in the green bars, people consistently do have a favorite person they want to work with for continuity of care. But if you look at the red line, it's dropping consistently and irreversibly. You just cannot get continuity of care with your primary care doctor. It's too complicated, it's too fragmented, and it's going to get worse every year. And meanwhile, these primary care physicians or healthcare professionals in general have not been trained in behavior change. And chronic disease management is all about behavior change. So when my mother was asking me to take the medication, when she was teaching me how to look at my test results, that's the work that has to be done. But medical school just teaches you how to prescribe the medication, and then it's the patient's problem. Luckily, there are solutions coming. This is an app called Holly Health, and what they focus on is reinforcing good habits. So you pick good habits around your sleep, your exercise, your eating, whatever it is, and you can see the user interface. I like it. It's very cute. My only point is you can see the user interface is completely different to medicalized user interfaces, and what you want is many more apps like that, trying to change people's behavior, and we'll see what works best, and you take it from there. This is another one, which is Chiron. So they work with specific diseases where the citizens are running N-of-1 trials with each other. So this is with fibromyalgia they started. So what happens if I try this today? Does that affect my symptoms for the rest of the week? And then they exchange with other patients what worked, what didn't work, and they monitor how it works for themselves and so on. And then you have AI driving the whole thing. So I'm going to end on this one. The last month has been extremely disruptive if you've been watching the USA. So they started in the USA with Google saying they're going to access personal health records for anyone who's paying a subscription. They get the medical records from the EPRs. They put it into Gemini AI. You can see the Fitbit health coach that they're putting that brand under. And then OpenAI announced the same thing with their health app, which has hundreds of millions of people every week using ChatGPT in general to ask healthcare questions. So again, they put a tiered subscription which says they'll pay for get your medical records, and then you can start chatting with it. And then the week afterwards, Anthropic did the same thing with their own platform. Now, I would say the USA is the worst market to do this in the sense that they don't have a national identifier like so many European countries do. HIPAA is incomplete. It's old legislation that hasn't caught up with healthcare needs. And the data quality and quantity are bad because all the providers are trying to lock in the data. And so they only release it grudgingly, uncoded, unstructured. But these AI systems are stepping in, trying to fill in the gaps because the demand is clearly there. And you know that demand is not just in the USA, it's in every country. The hundreds of millions of users every week who are asking ChatGPT questions are from all over the world. And for all the mistakes that these AI systems are making, they do improve every week, and they do they have the potential for behavior change in a much more scalable way than any healthcare system can provide. Now, I'm just going to finish on this slide because the next question is, of course, how do you evaluate and assess these things? And my colleague Liz is the world expert on doing this. But I'll just say, if you want the things I've talked about, they're all available, open access on phr4gov.org. Thank you very much for listening.
Passing the baton. Shall we have a seat? Yeah. Thank you. I'll take this one.
So I'll get you on my left second.
Perfect. So let me ask you, you've built now the world's largest health records patient database.
Yes.
How did you do that? Because, I look at different countries that I'm closer to, and I just see the amount of inertia being insane, and for someone to push through from 2008 to 2026 is remarkable. How did you do that? How did you stick with it? And how have you been able to be so successful in places where countless actors have somehow gotten stuck?
One of the things we look for people who join the company is what I call patient impatience. So you must be impatient with healthcare because it's unacceptable what is happening. But you must be patient enough to stick with it, and instead of leaving and saying, healthcare industry is terrible, I'm leaving. And so if you can sit with that contradiction for a long time, big things can happen. Because if you can outweight governments then start deploying things at enormous scale. But it's a difficult mindset.
Patient impatience. Ladies and gentlemen, how many of you possess this? Yes, a few. For 20 years. Well done. Keep on being patiently impatient. I love that. Some argue that data location matters. But increasingly you can sort of say, well, with the cloud and with everything, it might matter less. Then again, you know, sort of from your perspective as a patient leader, as a systems leader, and also with a very international global view to this, I think you said you were in 10 countries, 12 countries? 10 countries. Why does it still matter where health data resides? We are becoming, as citizens, increasingly, I think, increasingly traveling all over the place, so we tend to go everywhere. But why do you think it matters where the data resides, and where do we stand on this debate today?
So from the citizen's perspective, the data must follow them wherever they are, wherever they receive care, wherever is, and whoever they get help from. So we have one of my colleagues, her aunt was sick in London. Her uncle was checking her results in Australia and telling her overnight what to ask the doctor the next morning. So from the citizen's perspective, data goes wherever the citizen wants it to. But where you store the data determines the regulator. And we're all watching the news. People care about which regulator you're under. And in particular, the European values and the European regulator is looking more and more attractive to different citizens around the world. So I think that where data resides at rest does matter, and what the regulator makes the marketplace do does matter. But you mustn't use that as the excuse to prevent the citizen themselves from accessing it wherever they need it in the world.
As you look forward, you sort of gave us a bit of an outlook with some of these big hyperscalers taking a stake in a space which you have been active for way longer than they have been. How does it make you feel? Is it sort of like, yes, we are making forward movement, or is it like, yes, we're making forward movement, but unfortunately kind of not quite in that direction where it should go?
The thing that interests me is their business model. So everyone assumes their business model is take the data, monetize it, advertise it. That's not their business model. It's a premium $20 a month subscription for AI explaining your data to you. And the reason I find that interesting is, so we get paid by governments primarily to release data to patients because a person with their data is cheaper to look after. Wonderful. That's great to have. And it delivers at very large scale. But when the government is your customer, the requests they make aren't always consumer friendly. But if you now have an extra revenue model from the consumer saying, "No, I want you to explain it to me in a way I can understand," now you can make R&D investments for what the consumer wants as well as what the government demands. So that to me is what's so interesting about these companies coming into the sector. They are financing big jumps in user interface that the government doesn't care about and shouldn't care about, but you have a way now of financing them.
And so you think this is, for you, actually a positive movement?
Yes. It's making the pie bigger for everyone. It's adding the consumer as a stakeholder with a say on the user interfaces. Plenty to be managed around that one, but it's a great step next for us to move forward.
Last question. As you have been involved in this conversation around digital trust, way before I think many consumers even started caring about digital trust. What are maybe some recommendations that you would give, as we have here leaders from the public sector but also from the private sector? What are recommendations from your experience that you could pass on to us that we can learn from?
So from the private sector, it's about being patient with government. The problem for a government employee is No one says thank you. Everyone criticizes you in public. And the best outcome you can have is that you do your job and you get a 2% pay rise next year, right? It's a very difficult environment. So be patient with them, because if you do the right thing for them, you can make change at country scale. And conversely, for governments, you need the private sector to do the experiments you can't do. And advances only come from experiments. So the problem with the public sector is you're only allowed to do everything or nothing. And when you go to everything, the mistakes will happen with everyone. So you need the private sector to make lots of small mistakes. The ones that fail, you shut down. The ones that work, you double down on. And so that's your opportunity to give your citizens. So these two very different cultures have to find ways of working together. We need that in every country.
Thank you so much. It's been a real pleasure. Dr. Mohammad Al-Ubaydli, thank you very much.
Thank you.